Hello, Professor Tasia and fellow SPED 343 classmates. Our presentation topic is traumatic brain injury, which is abbreviated TBI. This presentation was created by Kylie Griffiths, Mallory Pina, Robert Suhrie, and myself, Hunter Stiglitz. First, I'm going to define traumatic brain injury. Like stated earlier, TBI stands for traumatic brain injury. This is a brain dysfunction caused by an outside force, which is usually a violent blow to the head. This type of injury affects every aspect of life, including personality. The symptoms of traumatic brain injury may appear right away, or they can take weeks to appear. These symptoms are on a broad spectrum and vary from person to person. For example, a person who is suffering from TBI can appear normal at one moment, and at the next moment, life can change abruptly. A huge consequence related to this brain dysfunction is that most times a person does not realize that a brain injury has occurred, which can put them in further danger. And unfortunately, TBI is commonly looked over by medical professionals while they're trying to save their patient's life. There are two classifications of TBI, and they are mild and severe. With mild TBI, a person may experience loss of consciousness, confusion, and/or disorientation for less than 30 minutes. These patients will show normal results on a MRI and CAT scan, but they will experience cognitive problems including headache, difficulty thinking, memory problems, mood swings, and attention deficits. With severe TBI, a person may experience a loss of consciousness for more than 30 minutes and a memory loss that lasts longer than 24 hours. Impairments can range from loss of high-level cognitive function to a comatose state. Survivors of severe TBI may experience limited function in arms and legs, abnormal speech or language, loss of thinking ability, and emotional problems. The prevalence of people with TBI is much larger than expected. According to the United States Centers for Disease Control and Prevention, 1.5 million people in the United States suffer from TBI each year. 50,000 people lose their lives each year from TBI, and 85,000 people suffer long-term disabilities resulting from TBI. The causes of traumatic brain injury are very diverse. The top three causes are car accidents, firearms, and falls. Young adults and the elderly are at the highest risk because of their age. The number one prevention technique is the use of common sense. For example, practice motor vehicle safety by wearing a seatbelt, never driving under the influence, and using appropriate child safety seats and boosters. Practice gun safety by keeping weapons unloaded in a locked cabinet, and practice fall prevention by using the rails on stairways, watch out for obstacles in walking pathways, and wearing a helmet while riding a bicycle, participating in contact sports, horseback riding, and while skiing, snowboarding, and skateboarding. These prevention techniques are very important because there is no cure for TBI. Recovery from traumatic brain injury is a functional recovery that is based on mechanisms that remain uncertain because brain injuries do not heal like other injuries. Recovery from TBI depends on the person and varies on an individual basis. For many people with TBI, long-term rehabilitation is necessary to maximize function and independence.
Preparing for reentry. In order for students to have a successful readjustment back to school, it may require adaptation of the learning environment, acquisition or reacquisition of skills, provision of compensatory aids and strategies, as well as support services from special education providers. Communication and coordination prior to reentry is key. It is important to start early. Advanced communication and coordination between the hospitals, therapists, family, and the school system is a critical first step in students' return to school. Preparing both the students and teacher for the transition is a process that occurs through a series of steps. These steps take time. The process must begin well in advance of the actual transition. This includes activities to prepare the student for changes, such as providing information about the new setting, visits to the new setting, and opportunities to meet with new teachers. It also helps to include a series of meetings to help teachers plan for transition. Gather information. Lots of communication done should be to gather medical and functional information to assist the school in developing an appropriate and individualized plan for the student's re-entry. To identify potential problem areas and develop plans to address student needs, carefully examine the physical and cognitive requirements of the environment to which the student is transitioning. Scrutiny of the curriculum, discussion with all teachers involved, and visits to the setting all contribute to providing the comprehensive information required for effective planning. Should be established prior to re-entry. This communication should be ongoing and the re-entry plan determined prior to the student's return to school. Successful transition begins with educators' awareness that adjustments to transitions does not occur naturally with students with TBI. Therefore, all transitions require planning. The benefit to this is saving substantial amounts of time later by avoiding problems that occur because the student or teachers were not prepared for the change. Must be unique to the student. The educational program and classroom interventions designed to benefit students with TBI be based on the unique needs of each individual. Specific information about the student should be provided. Detailed information about the student's medical condition, education needs, learning styles, behavioral strategies, and therapy requirements must be shared with all persons who will be involved with the student. Valuable time can be lost unless everyone has a thorough understanding of what the student's needs are and what education methods have been proven successful. Ongoing assessment is necessary. Because of the rapid changing needs and recovery of children with TBI, initial evaluations conducted while in the hospital may not be accurate descriptions of the students at the time of their re-entry into school. Therefore, ongoing observation and assessment of students after their return to school is usually required to develop appropriate interventions and to re-evaluate the effectiveness of interventions. Common consequences of TBI. There are many common changes as a result of TBI. Children who have sustained a TBI may exhibit a wide range of newly acquired deficits or alterations in cognition, physical mobility, self-care skills, and communication skills, as well as changes in emotional and behavioral regulation, which may significantly affect school functioning. Things that will affect recovery. The nature and severity of the injury, acute medical complications, age of the child, pre-injury characteristics, and the interaction of these factors with the family system and environment will affect the course of recovery and school outcome. No two situations are alike. Each child will present a unique pattern of sequelae ranging from mild to severe. Just as no two people are exactly alike, no two brain injuries are exactly alike. For some, brain injury is the start of a lifelong process. The injury requires access to a full continuum of medically necessary treatment and community-based support furnished by interdisciplinary teams of qualified and special clinicians working in accredited programs and appropriate settings. Executive function. Children with frontal lobe injury typically experience greater difficulty with executive function, which includes attentional processes, self-regulation, goal setting, initiating, and inhibiting behavior. Behavioral and social impact. Many behavior and social problems observed in children with TBI are related to poor executive functioning. They may also have problems with organization, planning, prioritizing, analyzing tasks, and completing a sequence of activities. Cognitive impairments. Cognitive impairments can include memory problems, slowed information processing, and language disturbances. Memory impairment, which is recalling and retaining information, is one of the most common deficits associated with pediatric TBI. Physical impairments. Physical functioning can also be markedly impaired following severe TBI. Loss of function in all or some extremities, spasticity, decreased motor speed, and poor coordination in fine or gross motor movement may require physical and environmental accommodations and/or assistance with self-care skills such as feeding and toileting in the school setting. Assessment. When assessing children with TBI, the assessment goal must be expanded to delineate the specific cognitive challenges each child faces. Effective assessment requires either referral of children for neuropsychological assessment or, within the school system, a shift in assessment tools to those that focus on cognitive deficits and strengths, in addition to those addressing traditional academic concerns. Functional Behavior Assessment, also known as FBA. The special education team at the school, such as a school psychologist, special educator, and speech-language pathologist, uses a functional behavior assessment to examine, measure, and treat many deficits associated with TBI, particularly behavioral changes related to increased impulsiveness, inappropriate emotional outbursts, aggression, and inattention. Behavioral function categories. The following are the 4 typical categories of behavioral function. A. Gaining attention from peers or adults. B. Escaping or providing a non-preferred task or person. C. Gaining access to tangible reinforcement. And D. Gaining sensory stimulation or relief. Antecedent behavior consequence, also known as ABC. An ABC assessment is one simple means of conducting an FBA. In conducting an ABC assessment, assessors record the events that occur immediately before and after the unwanted behavior. Kinds of information collected. They collect information such as time of day, with whom the behavior occurs, specific places, other events, and rate and type of reinforcers are collected to help select an appropriate replacement behavior and an effective intervention plan.
Be covering structuring the environment, which is how the environment should be arranged for students if they have TBI. So let's begin on this. Because a traumatic brain injury involves a progressive recovery process, a student's physical and mental endurances may be limited during their initial return to school and will steadily improve over time. For students with TBI, consideration of different schooling options may be necessary, including homeschool approaches, gradual increases in school attendance, or change in class schedules to a less demanding course load. It is important for students' academic programs and schedules to be flexible and customizable to fit their changing needs as they progress in the recovery. Class enrollment and expectations should be based on students' current rather than their previous academic performance. For students with TBI, it is important that as teachers we move slowly with them rather than push them through their classes and require them to make up any assignments that they miss. Students with TBI should be allowed additional time to relearn concepts and regain skills. Structuring the school environment is a way to manage antecedents or consequences contributing to many problem behaviors and to prevent the behavior from occurring again. If attention, sensitivity to overstimulation, poor risk assessment, and emotional control are identified in a student with TBI, the classroom environment should be quieted and simplified to help the student regain control and further their learning. To support a student that has TBI, in the classroom, noise and activity levels should be controlled, and unnecessary distractions and sensory stimulations, including noise, light, and movement, should be minimized. Proximity controls may require seating the student near the teacher or by an appropriate peer, providing a study cube, removing extra materials, including pencils, books, and papers, and dividing work or task links into smaller sections. Students may also use headphones or earplugs to reduce external noise and to help them concentrate. They may also need a designated space in which to rest or to take a time out from the stimulation and be allowed to have downtime. Special attention should be given to the physical arrangement and structure of the classroom to facilitate mobility and accommodate physical needs. A student with poor mobility may need assistance to participate in typical classroom activities and may need to be specifically taught and allowed to rehearse the routines of the learning environment. Students in secondary schools may have a particularly difficult time navigating hallways and moving from class to class. Providing extra time for transitions, such as leaving class a few minutes early before other students in the hallways, is a common recommendation. A peer buddy or an adult aide may be assigned to help with the hallway transitions to provide physical assistance, such as in the lunchroom or the bathroom, and to help ensure the student's safety. Next, we are going to cover accommodations that can be made to support a student with a TBI. A student with a TBI benefits from a predictable and consistent routine. Consideration should be given to the length of school day that a student can tolerate, their nutritional needs and their fatigue levels, and need for rest breaks. Classes should be scheduled to capitalize on optimal attention periods. Students with challenging behaviors are more likely to engage in appropriate, on-task behaviors when presented with a positive, well-understood daily routine. Providing a written schedule or posting a visual chart of the daily routine will help reduce confusion. Students may need simplified instructions, written or pictured checklists of task steps, maps, or strategically placed signs to carry out tasks. It is important to involve the student in reviewing the schedule at the beginning of the day and verbally reviewing the steps with them. Transition times and out-of-classroom activities should be pre-planned and structured to help reduce stimulation and emotional distress on the student. Using auditory or visual cues to signal changes in the routine and giving the student advance warning is also helpful. Teachers of the same student should agree on environmental strategies and apply them consistently throughout the school day. Another way of altering the environment is to provide external devices and cues that the student can use to compensate for organization, memory, and motor deficits. Assistive devices can include technical equipment and materials such as tape recorders, calculators, electronic spellers, word processors, computers, timers, alarms, equipment for mobility, such as a wheelchair, walker, electronic scooter, or such. Other external cues used to remind students include labels, map checklists, pictures or icons, photograph cues, post-it notes, calendars, planners, and journals. A memory notebook is one such compensatory aid that has been used to assist in memory and organization following TBI. The memory notebook can be very flexible and may contain maps, checklists, feeling logs, and other information such as telephone numbers and names of contact people. Students should be used to train this book to help them in any way that they need. A simple way to help students with the TBI is by modifying existing materials. Typical authorizations that allow students to participate at their level include providing carbon paper notebooks, large print books, books on tape, and graphic organizers. A similar approach involves altering the expectations for student participation. For example, allow more time on tests, reduce the amount of written work required, provide exams in multiple choice format rather than recall format, and give pass-fail grades rather than letter grades. It is important that students are not simply given aids or devices to use without academic training to recognize when and where appropriate aids are useful and how to use them properly. Next, we are going to cover the available resources and services to support a student with a TBI. Because of the extreme variability in outcome following a brain injury, a wide range of services and accommodations may be needed and highly individualized planning is required. Many students with mild to moderate TBI can be integrated into existing school programs in regular education with some adaptations and modifications. Students with TBI who attend mainstream classes may also receive accommodations or related services under the Rehabilitation Act of 1973. For students who do not require special education but need some accommodations to participate in regular school programs, it is important to complete a 504 plan and formalize suggested accommodations with parents and teachers. Since 1990, students with a TBI are eligible for services under the Individuals with Disabilities Education Act under the category of traumatic brain injury. To receive services, the brain injury must adversely affect students' educational performances, and students must require specialized instruction. Special education programs are frequently selected as an intervention of choice for students with TBI because they can provide a lower teacher-to-student ratio, individually designed curriculum and specialized instruction, and necessary therapies. In one follow-up study of children with head injuries, 30% required special education intervention at 1 year post-injury, and 78% of those with severe injuries were placed in special education. In addition to resource services for academic and adaptive needs, students may receive services with a speech or language pathologist, occupational or physical therapist, psychologist, or other related services. As with the 504 plan, an IEP must be written, reviewed, and revised annually. However, because levels of functioning may change rapidly with the TBI, it is recommended that IEP reviews occur more frequently. Although there may be one or several students with TBI attending a specialized program or class, a designated TBI classroom is not typically offered. Students with TBI may be placed in a non-categorical program in which students are grouped by functional skills and ability levels, and provided appropriate curriculum, content, and teaching strategies based on the abilities.
Hello everyone, this is Robert Suhrie, and I will be discussing specialized teaching strategies. While each student's situation is unique, teachers can benefit from the following strategies when working with those who have suffered traumatic brain injury. Challenging behaviors can be overcome through the following techniques. The direct instruction model is founded upon applied behavior analysis. It includes pacing, frequent opportunity to respond, regular feedback, and correct reinforcement to achieve and continue student engagement and learning. First, select the desired skill that you want the student to learn and present it at the level of the student. Next, give the student a purpose or context to help them understand the reason for learning the skill. Give clearly stated directions with the least amount of steps required to achieve the goal, and ask the student to paraphrase the directive. Break the task into small, manageable steps and demonstrate each step. Move at an appropriate pace and give the student opportunities to respond. Give immediate, positive feedback and error correction when necessary. The feedback should always be positive. Give verbal praise and encouragement often. Give clear instructions and give the student a chance to comply without interruption. Reinforce those who follow the request promptly. Give direct statements that indicate when to start the appropriate behavior, rather than asking them to cease an undesirable behavior. Look directly at the student, move in close, and make your request in a calm, soft voice. Speak clearly and softly. Never shout at the child. Limit your requests to 2 or 3 at a time, and be sure that you make reasonable requests. Give the student time to complete your request. Recognize their effort with verbal praise and encouragement. In errorless learning, students are not allowed or required to guess on recall tasks. Instead, students are given the correct response and then instructed to read and then write the correct response. If errors are made, they are followed by non-judgmental feedback. Ideally, we want to teach students effective ways to express their emotional and physical needs. These skills will provide them with effective communication, coping, practical social and problem-solving skills. The goal is to reduce or eliminate problem behaviors. Functional communication training has been proven to reduce behavior issues in students with traumatic brain injury. Identify the communication function of a challenging behavior and replace it with a communication skill that provides the same function. Be sure to give reinforcement when the desired behavior is displayed. Our intention is to train the student to engage in self-management. One method is to initiate students to record their behavior at random intervals. You can prompt your students to mark yes or no on a sheet of paper when asked about a particular desired behavior. Examples include, am I listening? Or am I behaving? Or am I working? Rubrics, checklists, logs, and other methods of self-management are used with this technique. Many students who have suffered traumatic brain injury have difficulty with social adjustment after their injury, specifically regarding communication and conversation. Practice in initiating conversations, staying on topic, taking turns in sharing, and being a good listener should be initiated. Remember to give positive praise to reinforce the desired behavior. Children can also be videotaped and then review their performance on self-rated scoring sheets. Positive reinforcement is a powerful technique. Praise should be given more frequently than admonishment, ideally at least at a 4-to-1 ratio. Praise should be given immediately and should be specific to the desired behavior that has been displayed. Each successfully attempted skill should be praised. Nonverbal reinforcers and praise techniques include high fives, thumbs up, or a simple smile and nod. Token economies, tangible reinforcers, and special privileges are also ways to reinforce the desired behavior. Behavior momentum involves making simple requests that you know your students are able to fulfill. Praise or reinforcement is given immediately. Once some momentum has been built, requests involving more difficult or undesirable tasks can then be made. Consequences can be effective methods of intervention, but should be natural and related to the specific behavior. Those with frontal lobe injuries typically do not comprehend the cause and effect sequence of negative consequences. Thus, suspensions and expulsion are generally not good methods of intervention. Natural consequences could include constructive feedback and guided compliance. Extinction is also an effective method. Ignoring the poor behavior and re-engaging and reinforcing once positive behavior is displayed is one way of implementing the extinction technique. Teachers should strive to anticipate students' difficulties and be ready to offer verbal or physical prompts to redirect the behavior. Timeouts or resets can be implemented to help the student regain their composure and focus. This is effective for students who exhibit explosive, angry reactions. For example, ask or prompt them to take 5. Now let's summarize some of the topics that we have discussed. The challenges faced by students who have suffered a traumatic brain injury and those who work with them following the injury are numerous. However, when provided with the right tools, techniques, and strategies, students can reach their maximum potential. Teachers play a critical role in helping students reintegrate into the school environment. Educators, therapists, and parents must work together in order to create comprehensive plans based on each child's strengths and weaknesses. With the right plan, adaptation, and execution to help these students acquire and relearn skills, most children can overcome barriers and achieve academic and social success.
It's Kylie again with some informational videos on TBI. Here we have two great videos on TBI. The first is an interview with Jane Gillette, a neurologist in a children's hospital. She discusses the importance of educating teachers about a child's needs after a TBI. The second video is about a young boy and his road to recovery. He discusses his experiences going back to school after his brain injury and the challenges that he's faced. Both these videos are short and provide excellent insight into TBI and recovery. Next up, we have some resources and websites for teachers that have students with or want to learn more about TBIs. First up, we have some resources to help teachers learn more about the brain. An Educator's Guide to the Brain is a great write-up that covers all aspects of the brain, what occurs where, and what each part of the brain does. The website also has loads of information on TBI, even pediatric TBI. The Interactive Brain. Here is a great model of the brain that you can move around and click on to learn more. What is great about this resource is that when you're learning about the different parts of the brain, you get to physically see what part of the model you are learning about. There are numerous websites and organizations to both help people with TBI and to help inform others about it. The Brain Injury Association for America was founded by people who wanted to improve the quality of life for their family members who had sustained brain injuries. Here you can find information about your state's association. The National Resource Center for Traumatic Brain Injury also has numerous resources, as you can tell by its name. One in particular is a Chat with Pat. Here letters are sent in by individuals asking questions about TBI and are answered by a doctor or a specialist in the field. While you can no longer send in a letter, they kept the more informative ones online as a resource for others. TBI Educators has resources available for those wanting to help educate others on TBI. Here are two more helpful organizations that provide information on TBI. Brainline has numerous videos and multimedia available. They also have personal stories and keep a tab on the latest research in the field for TBI. The TBI Recovery Center gives an overview on TBI and looks into the recovery process and time. Thank you everyone for watching our presentation. We hope you have learned more about TBI and how to support your students with it.